We know that the decision to operate and what surgery to do is influenced by the individual surgeon. But then it's being increasingly recognized that total knee replacement may not be the only solution for the patients with knee osteoarthritis. We have talked about the age quake. We have talked about the silver tsunami. We know that the number of elderly are going to just double by 2040 all around the world. And then when you treat these old patients, you have to balance the recovery with the complications. So we are going to talk about the indications of UKR, why UKR in elderly, and challenges while doing UKR in elderly. So ideal patient, we all know, is a anterior medial osteoarthritis with intact anterior cruciate ligament without any laxity. But we don't operate in inflammatory arthritis, tricompartmental arthritis, MCL laxity, or the patient non-compliance. So this is classically a varus which disappears when the patient flexes the knee, because the posterior part of the cartilage on both sides of the joint is intact. So the deformity disappears. And this is how it looks on the X-ray. And this is how it looks on the X-ray and intraoperatively. And when I see a knee like this, I don't want to take out the normal cartilage from here, cut the ACL, and then put in something in place of normal cartilage, just replace it with plastic. So it really pains me more so in the elderly. We have been talking about the contraindications, but then we know that chondrocalcinosis, patellofemoral osteoarthritis, heavy manual labor, or weight is not a contraindication. And like this paper said, the age is not a contraindication. And that's the all or none rule, that there should be no cartilage left in the medial compartment, and all the cartilage in the lateral compartment should be intact. Otherwise, you don't get the desired result. So unless it's bone on medial compartment, you don't operate on this. Now, if you have cartilage loss in non-weight bearing areas or fibrillations and partial ACL degeneration, that's not really a contraindication, definitely not in an octogenarian. And sometimes even without ACL, it is very much on to do UKR, maybe with a fixed bearing, if you like, if you are the wiring type. So now it is being considered more and more in the elderly population. It actually allows you the kind of function which is difficult to imagine with the TKR. And there are a lot of literature to support the excellent outcome and survival rate of unicompartment knee replacement in elderly, whether it's octogenarians or patients over 75 years of age. And then this publication, in which we tested out the new instrumentation regarding the patient satisfaction and component positioning, out of the 100 consecutive UKRs, there were more than 70 who were more than 60 years old, and the oldest patient was 80 years old. And we found no difference in outcome scores between more than 60 or less than 60 years of age. Another paper in octogenarians versus younger patients, length of stay is not affected by age, and age is not a factor which determines complications. In this particular paper, the 10-year all-cause survival of UKR in less than 60 years of age was 91%, and it was actually far more at 96% in patients who were 60 years or older. In this particular paper, even in ACL deficient patients, the UKR failure was not higher. Of course, the fixed bearing showed better results than mobile bearing in these cases. So in elderly, even if the ACL is deficient, if the disease is limited to medial osteoarthritis, UKR can lead to good outcome and survivorship. Now, what about the outcomes? Do they differ from TK when it comes to UKR? In this, one of the most quoted matched pair study of over 100,000 patients from the registry data, it showed that the TKR patients are 4 times more likely to die in the first 30 days after surgery, and about 15% more likely to die during the first 8 years. And the inpatient stays are longer. Readmissions are more likely after TKR compared to UKR. So UKR patients also show better forgotten joint score with similar survival analysis and compared to TKR at the end of 5 years. When it's compared with TKR, UKR patients show faster initial recovery with comparable clinical rate at midterm in patients older than 75 years of age. And in patients more than 85 years of age, the early medical complications are fewer with UK than with TKA. So there's a compelling argument. This particular study showed that 82% reduced risk of any complications was there with UKR as compared to TKR without any compromise of the patient-related outcomes. So there's a compelling argument in support of the safety and effectiveness and survival of the UKR in elderly. The cost argument, of course, remain important. There is in this paper, it was showed that they have similar cost effectiveness, whereas many other papers have shown the UKR is much more cost effective because of the faster rehabilitation, lower inpatient costs, improved quality of life, and in low demand patients, there's similar implant survival and decreased perioperative morbidity and mortality. In this particular paper, the UKR was shown to provide better health outcome and more cost effective compared to TKR, particularly in the elderly age group. The Medicare policy works better with UKR, and then there are more complication rate with TKR and a longer length of stay. So while you can easily do UKR as an outpatient procedure, there's more and more opinion against doing that for TKR in UK, in US, because of the length of stay and risk of complications. Now, when it comes to cost effectiveness, this particular paper says that in a patient less than 60 years of age, high tibial osteotomy is more cost effective, whereas in patients more than 60 years of age, UKR is more cost effective. Coming to the survival and revision rate, the revision rates are determined by patient symptoms, health of the patient, ease of revision procedure, and chances of improvement following the revision. And you can see it is very difficult to revise these as compared to a UKR, which is just so tempting to revise, even if there are persistent symptoms in this and this, you will be more inclined to revise this. So in two classes of implants with identical functional outcome, the implant which is easier to revise will have an artificially high revision rate. That has been established, and the revision risk is higher when the surgeon has a low volume or low usage. And then if the surgeons perform 20% of their joints as UKR, their revision rate can be sufficiently lower. The re-revision rate of failed UKR is equivalent to the revision rates of primary TK and less than the revision rate of revision TK. So it's a good bargain. About our experience, we have completed 2 projects and mentored 3 postgraduate theses. I did this first as my first UKR in a mother of our neurosurgery registrar, and then she came back after 6 years to get the other side done. We have analyzed the data of our patients above 70 years of age, 75 knees in 70 patients, 31 were male, surprisingly. We need to study whether it's the male who remain suitable for UKR for a much longer time compared to females who get a tri-compartmental disease much earlier, probably. The BMI was 28.5 and the minimum follow-up was 3 years, going on to from 3 to 8 years. And remember, 60% of these patients had more than one comorbidity. So these were not fit ASA grade 1 patients. Average length of stay was 3 days. Blood transfusion was given in 8 patients. 2 patients had to stay in ICU. 1 patient had cardiac ectopics. 1 had resurgery, and that was the reason for readmission because of bearing dislocation in the same patient, and there was no mortality at the end of 3 years. The mean operative range of motion preoperative and postoperatively showed significant improvement, and most could squat. The challenges are severe tibia vera osteoporosis, hardware in situ, complications, and revision. The tibia vera incidence is higher in Indian patients at around 50%, and it has bearing on forces across the knee, alignment of the implant, and longevity of the implant. And so we resorted to navigating our unicompartmental knee, particularly in elderly patients, because we have published our results in JBJ's American showing that there is significantly less embolic load in patients when they have navigated surgery. Although the embolic load is not much in UKR, but then our other purpose was to look at the alignment. And if the patient had more than 5 degrees of residual varus even after valgus stress, or more than 10 degrees of hyperextension, we switched over to TKR in order to avoid failures. And this was a patient who had intramedullary nail in situ. He was 70 with comorbidities, and the options were to remove the nail and do arthroplasty, do pinless navigated TK, or try UKR. Now, this is what we did. We did a UKR on him, but because it was not possible to pass the intramedullary rod, we made a hole and used a spigot in this hole and used that to guide the femoral jig. Now, quickly about complications. Now, this was an osteoporotic lady. We have talked about osteoporosis. I am quite worried about doing partial knee replacement in patients who are severely osteoporotic. This patient intraoperatively developed a fracture, so she had to be fixed, and she possibly loaded her opposite side too much because she was told not to put weight, and after 3 weeks, she fractured on the other side. And then she had to be operated on the other side as well. But then fortunately, she went on to heal on both sides. So must keep that in mind in osteoporotic bone. This patient had a complication unrelated to surgery, had an intertrochanteric fracture, which had to be nailed. And then there is a problem about bearing dislocation. You should be very careful about it. That is most commonly because of the surgical errors like inadequate gap balancing and impingement with the osteophytes. Your component should not be too far medial or too far lateral. And then you should put as little cement posteriorly as possible. And once you have a bearing dislocation, you can retrieve the bearing. If it is anteriorly, it's easy. If it's posterior, you can manipulate it and bring it to an accessible side. You can remove the femoral component, remove the bearing and put it in again, or you can just leave it there and put a new bearing. The recurrent dislocation is most commonly because of the MCL damage or a serious flexion extension mismatch and must be converted to a TKR. And you should not change, revise a failed UKR to another UKR. And if at all you need to revise, this is intraoperative picture. It's not that big a problem. And this is the chapter on the revision of unicompartmental knee to total knee in my book. So to take home message is that unicompartmental knee arthroplasty is a safe. It is because of the safety that I am inclined to use it in all elderly, particularly with the comorbidities, and I'm able to send them home and they continue to do very well and they continue to live. Remember, there is a certain mortality to TKR in elderly, and that's what we have also shown is possible with UKR. Thank you very much for your attention.